My name is Alia Azariah. I'm the director of aftercare at Safe House Project. I am also a person with lived experience. I've been able to moderate these panels for, I think we're in our fourth year of our webinars right now. And the hope with the webinar series is that they will bring together experts on any topic, topics that you all as attendees have identified as important to you. It's exciting to be able to bring this to the national field. I feel like so many of the conversations we have in this work are regional. And it's exciting when we get to bring people from all over the place to figure out how are we doing things well in different areas of the country. So really looking forward to bringing this webinar to you all today. As most of you likely know, healthcare systems are one of the greatest opportunities for impacting survivors that we have. There's studies that say that anywhere between 85 and 98% of people who experienced exploitation will interact with a healthcare worker during their exploitation. So one of our greatest opportunities for intervention, for relationship building, for setting the platform for what someone believes about people who are in helping positions comes from our healthcare systems. And I'm excited to bring each of our attendees to you so that we can, or each of our panelists to you, so we can talk about the systems that they have created inside of the healthcare settings that were specific to address people who've experienced exploitation. So I'm going to start with introductions. I'm going to start with introducing Daisy. Daisy Sherman is the CSEC program coordinator for Children's Hospital of the King's Daughters, Child Advocacy Center, and a diplomat forensic interviewer. As an advocate for trafficking victims, Ms. Sherman has provided briefings and education on child maltreatment, commercial sexual exploitation, and best practices to federal congressional offices, senior policy staff, state officials, and national human rights organizations. She's conducted training and provided a first responder perspective and representation in federal policy development of the Justice for Victims of Trafficking Act. So we are very excited to have her. Our team has worked extensively with Daisy over the last few years and with our placements team. And we're looking forward to getting more information from the CSEC perspective with Daisy as well. Dr. Pamela Davis. She graduated from UCLA School of Medicine in 1982 and joined the Northridge Family Residency Program, where she was awarded the Outstanding Resident Award at graduation. She then joined the program as a faculty member, and in 2001, she became the Family Medicine Program Director. Her life work has focused on teaching family medicine residents. She is passionate about family medicine education, healthcare access for all, and expanding the role of the family medicine physician in our communities. 6 years ago, Dr. Davis started a branch of the Medical Safe Haven at the Northridge Residency and has worked teaching residents about trauma-informed care and the care of survivors in a weekly clinic devoted to their survivor patients. She's lectured on care in a medical safe haven and assisted the Common Spirit team in starting new programs. And she is passionate about ensuring safe, trauma-informed, and excellent care for this vulnerable population. So we're excited to have you as well, Dr. Davis. That is my neck of the woods there. So glad to have you guys and all of the work that you're doing as well. And last, but of course not least, Dr. Stacy Reynolds. She's the Chief of Pediatric Emergency Medicine at Atrium Health and a practicing emergency physician and pediatric emergency medicine specialist. She serves as the medical director for the Atrium Health Human Trafficking Advocacy Team. This team provides consultation for patients with indicators of trafficking to provide individualized case plan, education, and placement into restorative services in collaboration with community partners. And the team also serves at-risk patients with screening, education, and resources. So thank you for joining us as well, Dr. Reynolds. You see Abby in one of our survivor support specialists who lives in that area, who is a big fan of you. And we've gotten to work extensively with the Atrium team in placements as well for those who have needed those services. So glad to have you here also. So we're going to jump right in, and I'm excited to get to hear a little bit about the background of how these initiatives started. So whoever wants to start us off, sometimes I'll pick on people, but I guess I'll just open it up to whoever wants to start us off. What made your healthcare system decide to build a focused response to human trafficking? Why was that important to you and your system?
I can start. Common Spirit, as many of you know, is a very widespread hospital-based system, but we have ambulatory sites as well. And as I'm sure Dr. Reynolds will speak to, often human trafficking survivors and victims present to hospitals, to emergency rooms, to urgent care clinics. And I think the lead of our program, Dr. Ron Chambers in Sacramento, saw this very acutely. For some reason, Sacramento is a huge population. And he also is a program director of a family medicine residency. And he and Jennifer Cox started the medical safe haven in that area in response to trying to take the healthcare out of the emergency room. Not that it's not wonderful there, but it's not what all the patients need all the time. And developed our clinics in response to the great need that we saw in many of our hospitals.
Yeah, absolutely. I think I, as a survivor, used the emergency room for healthcare many times. So that makes sense. Yeah. Dr. Reynolds or Daisy?
Yeah, my experience was I missed a case. So I had a teenager that I knew had been assaulted, and I knew it wasn't the first time. I started to talk to her about her social history in front of what I thought was her 16-year-old friend, and that friend lost it and was like, "You don't have to talk to her about anything and forget her." And so we separated them, but we didn't really have a coordinated response. So they wound up being reunited, inadvertently by a well-meaning teammate, and the girl wound up leaving before she even got imaging. So then when we tried to involve law enforcement and our legal team, they said we didn't even have documentation of injury, so it was hard for them to take action and take next steps. And then a couple months later, I sat in a training with the FBI about human trafficking. And during that training, I kind of felt my stomach drop because I thought, I bet that's the dynamic. I was thinking it was IPV and that this was her friend, but probably this was her supervisor and it was an HT dynamic. So then after that, we're like, okay, well, I didn't know this was happening to kids in our community. Like, certainly we can get better at this. How do we find the cases? But even after training our teams and trying to do it on a one-on-one basis, kind of diluted across the whole team, we just really struggled to get enough case learning. So then we pursued a grant and developed a centralized team. So now teammates see indicators, they can call us. And that really helped us build a lot more extensive case learning and helped it sort of take off as a program, build a better healthcare response from that.
Thank you.
So this is Daisy. I'm work at our Child Advocacy Center, which is a hospital-based pediatric level 1 trauma center here in Norfolk, Virginia. And very quickly into our interactions with children who had experienced trafficking was the medical component. And we immediately, probably within the first few months of really identifying these victims in the early 2015, 16s, we realized we need to have our medical teams and hospital on board because we're level 1 trauma center. They were coming in through our ED doors, and we didn't have anything in place. And so we really started from ground zero to develop our program, with very trauma-informed approaches. Our Child Advocacy Center is across the street from our medical campus. So we're very in close proximity, which was just amazing to have that, quick access, because our ED would call us and say, "Hey, we have a kid in here. We think something's going on. Can you come in and assist?" So we kind of started like that, and we really just filled in, the training as to what our physicians felt like they needed, as well as our, nurses and, all the medical professionals that were seeing these children. We created this coordinated response with all of our, our medical professionals from, again, from the ED, or if they were presenting someplace else or coming in for any sort of specialized care, we were able to have that quick access. So we would literally, my partner and I, who was a pediatric SANE nurse, would, hop across the street and go have those first interactions with the child to kind of prevent any, in terms of whether or not this was an open investigation that had to be very, carefully navigated, through those systems. So, and now that just kind of ran into creating a very specific protocols for if a child was recovered and we need to bring them in through the ED first, if there's any sort of acute needs, we have access to do that very quickly through back doors. We really went through everything, making sure the administrative, staff was aware that, people did not need to come into those rooms. We have a special place for our, federal law enforcement or local law enforcement to come in without it disrupting things. And then if the child does not have acute needs, they can immediately walk across or come across, be transported to our CAC, which is next door, so that we can kind of go through those measures. We'd also had some experience with moving our pediatric SANE out of the ED also. As everyone knows, that can be, quite chaotic and disruptive depending on what's going on. So really wanted to create this trauma-informed access to medical facility and medical professionals while still, keeping them under that CAC, Child Advocacy Center umbrella, and keeping everything very trauma informed. So our physicians were just fantastic, had some very specific requests for training that we were able to kind of give in real time as we went through, what the needs were for this population.
That's great. Thank you. And I'm excited for the next question because we get to see a little bit the framework of what each of you have built. And each system that you all have implemented is very different and it's was built to address different gaps, right? So Dr. Davis's gaps was definitely more primary care, family care, right? Like consistent health care. We have some more like Daisy's are more ED, like emergency needs or sane needs. So I'm excited to kind of get everyone to be able to see that there's multiple gaps. First of all, there's multiple gaps in access to the healthcare for survivors because as everyone should be aware, we encounter healthcare needs at different times in our lives, right? We do have emergent needs if the need comes from victimization, or we just have regular health needs from being a human that is living, right? And so excited to get to hear kind of the different solutions that you have all come up with to fill the specific gaps that you were working to fill. So if we could start maybe in the same order. So starting with Dr. Davis, what specific structures, programs, or tools has your system implemented to better serve survivors of trafficking?
Sure. Ours is, I think, pretty unique. We do have 7 sites, our medical safe haven. They're all embedded in residency programs, both internal medicine and family medicine. But what we try to do is we have coordinators who are our alliances in the ERs, and we work with an agency that deals with trafficking survivors. They refer the patients to us. So I call our medical safe haven kind of like kindergarten for healthcare, because it's a lot of our patients have not been to a doctor's office. Some just want to come in and go, what happens here? What's the vibe? And our first visit is an hour and a half. That never happens in this world, and our follow-up visits are 45 minutes. So we give them a lot of time. All of our staff is trained in trauma-informed care, from the front office to our advocate who leads them through it. We have an advocate embedded into the program who talks to them, who makes appointments, who arranges transportation. Once they get to us and they're actually in a room, we're very fortunate. We have a newly designed clinic. We have two doors on both sides, so the patient can always leave if they want to. We just start by saying, hello, how can I help you? We try to close computers. We offer trauma-informed care. And as you mentioned, Elliot, it can be related to their trafficking, and it could be my finger hurts. And we treat everything the same. And we want them to know, we try to treat them with dignity. We talk to them about how their bodies are treated in our office. We talk to them about, and if they want to talk about trafficking, we're there to listen. If they don't, we don't bring it up. So the nice thing is, because they're referred to us by an outside agency, we don't have to go into details unless they want to. We try to stick to whatever their medical needs they have. Eventually, if they go through these specialized, very highly intense clinics, when we decide they're ready to graduate, they get assigned to one of our physicians, and then they move into our regular clinic population with the advocate still there to help them pick up the pieces. And sometimes they come back to our clinic, and that's fine. We are open to all of those things. So it's really a specialized form of primary care devoted to survivors of both labor and sex trafficking in a very trauma-informed approach. But it really is the best of medicine in what I see and what I train my young doctors, that young doctors love it. They really, really respond to this kind of care and learning, both about the patients, but how they can impact their lives.
Yeah, I love that. Getting medical care can be one of the most anxiety provoking things for people with trauma and in such, you feel so vulnerable in those spaces that having a dedicated place to know that you can take care of your body when it's not failing, just when it needs maintenance, is really, really special. And I'm very proud that of California and Sacramento and Northridge and all of the places that we've been able to implement those. It's very exciting to me.
It's a fabulous model.
Yeah, it really is. Dr. Reynolds, do you want me to repeat the question?
No, I think you want me to talk about our model, right?
Yeah, yeah. What is
Yeah.
the model?
So our model is a little bit different. We work as a consultation service. So the main sites in the hospital that give us consultations are the ED, psychiatry, pediatrics, and then women and children. And we find women and children actually do a great job with these cases because their social workers spend a lot of time talking with women to figure out how to make mom and baby in the best possible situation they can when they leave the hospital. We will do consultations across, I think we're up to 24 EDs in our area now. And then we recently spread to Winston-Salem. So if they have a case, we work by phone or we work virtually to help those teams. And if it's a very savvy teammate that knows a lot about trafficking, then maybe it's just like, hey, you did a great assessment and what are your questions? You know, how can I help you identify resources? What can we do next? Or if it's somebody that's like, I see the indicators, but I have no idea what to do now, then maybe it's more, we take over as more of a frontline response for them. We have a system we use Epic Haiku chat. So that's how teams reach out to us confidentially. And then we also have, we have like a workflow built into our medical record that you can also generate a consult through the medical record. And then we get what they call a code hope message, and it'll link us to all the patient's records, and we can see like what the team's concerns were and like next day follow-up phone numbers and things like that for patients that had a safe place to go and just wanted somebody to contact them next day.
That's great. Thank you
Yeah.
so much. We
Yeah,
love the
sure.
follow-up. Yeah, absolutely.
So we also have kind of a multi-tiered approach. We are a pediatric level 1 trauma center, but we also, as everyone knows, these kids turn 18 at all sorts of different intersections with coming into contact with us. And so one of the gaps that we also identified rather quickly, because in the beginning, most of the kids that we were getting referrals for were 17, turning 18 any second. And so, forensically, a lot of things change depending on what their, medical needs are. And then, the laws change as to, certain types of interactions with over 18. So we really wanted to create, a medical home for these kids who were turning 18, had not had any significant medical care, or may have, some acute issues. So we also worked very closely with our medical school, which is also on our campus, which is amazing also, to develop a clinic for those 18 and older patients who were experiencing non-acute issues and that could kind of receive that long-term care. So similar to what Dr. Davis was talking about, we have scheduled appointments that are for an hour and a half. So there is a lot of time, there is a lot of patience, and all of the staff that are interacting with these patients have gone through our trauma-informed care, teaching in order to be able to volunteer at this clinic. So everybody kind of speaks the same language every time. We have access to, specialty groups if somebody needs to be referred on to something else. So anybody that has experienced any sort of sexual trauma, sex or labor trafficking, men or boys, sometimes women come in with children as well. So we're able to accommodate that, really making sure that there were no barriers to the access for medical care. So it's completely free. We will even Uber, the people there. And we even put specific structures in place to understanding, kind of going through what the person who gets out of that Uber exactly where they need to go, right? Because again, the anxiety of not knowing where you're going, who you're going to be meeting with. Sometimes these people are coming alone. We went through again and got very specific of what's the first thing you see when you get out of this Uber? Who's the first person you come into contact with when you walk through the door? Is it easy to get from, point A to point B? Is it easy to contact this person? We really dialed it back to very bare bones, making sure that there were, again, no barriers barriers to, just getting into the office. So that's been an amazing experience. We just had a girl that came in who I see for mentoring. She's also, 19 years old now, but went to our clinic a couple nights ago, and her entire demeanor changed after sitting with, these physicians for an hour and a half and really getting her questions answered, her anxiety about so many different body systems. Again, this was not an acute situation, but that's just been really outstanding to have that kind of aftercare or that medical home for someone to have, time to process through some of their medical issues. So, we do have both that acute level for minors and then that aftercare and medical home for our over 18, folks as well. And sometimes, our medical team will see both. It kind of just depends, but we really had to be careful to not have that hard line of once they turn 18, then what? There really weren't a whole lot of options. And so this whole process kind of came out of seeing what the gap was. They could come in through our ED when they're, 16 or 17 and receive this amazing medical care, but then they turned 18 and, they were saying, okay, they need to go see somebody else for kind of these long-term issues and so we wanted to create that continuity of care, that warm handoff. Everything is still on our campus. They had access to us. Sometimes I've accompanied them on those appointments. Sometimes they'll come debrief afterwards. So really trying to cover all those bases of training, the trauma-informed care, everyone speaking the same language, giving them plenty of time to interact with the medical professionals as well has just been instrumental. And, again, that continuity, and they keep coming back. And if they need referrals to outside partners, we're able to kind of handhold with that as well, because sometimes that is a barrier, is kind of keeping up with those appointments and that medical care. So again, really from the, age 0 all the way up through, we really wanted to make sure we were covering all of those bases and really not creating more barriers or challenges as they kind of age out of the pediatric setting and going into, that adult setting. And then, having kids and all of those things. So we still have seen people from, 15 who, 10 years later, now 25 with 2 children and are still able to have access to that. So again, that continuity has just been instrumental in creating that trauma-informed approach.
Yeah, absolutely. It's kind of mind-boggling to even like comprehend what an hour and a half long doctor's appointment, right, would be, and the amount of rapport one that you could build during that time. But like I have an incredible pediatrician for my kids, and when just the fact that she asks after a 15-minute appointment, do you have other things you want to talk about, is like mind-blowing, right? Like we'll keep going back forever just because she'll spend an extra 5 minutes. I can't even comprehend like what an hour and a half, what that could really mean for somebody. So that's so significant. And if I remember correctly, Dr. Davis's clinic also will serve survivors' children or the whole
Yes.
family
A
as
big
well.
interest of mine has been secondary survivors. We have a
Yeah.
large population and that's where it's kind of neat when family medicine, because we take care of the adults and the kids. And we've had a lot of family members and secondary survivors. And it's really great that we can bring the whole family in and try to give them all the same care. And we see a lot of trauma in the survivors.
Well, if you think about like the people that you care about, you're almost more likely to trust someone when you see them caring for someone you care about than when they're caring for you, right? So I love that as well. I have, okay, kind of a little impromptu question, detour, but I'm sure you'll all be able to answer this wonderfully. But from what I'm hearing, it sounds like there are a lot of partnerships involved in the systems that you have created. So could each of you touch on how important partnerships with non-medical service providers have been in providing care for your clients?
Do you want us to stick with the order? I guess it's easiest.
However, yeah, it
Um,
doesn't matter.
Yes, absolutely. We couldn't do what we do without our partners. We work with a couple of agencies. The main one is one called Journey Out. We work with another one called CAS. We've worked with several others, but Journey Out is our main partner, and our advocate works half time with them and half time with us. So she sometimes screens our patients before they come to us. Journey Out can talk to us at any time. If we do have a patient in the ER that we hear about, one of our residents, sometimes now they're all attuned to this, they can send them to Journey Out. What I like to tell the doctors is also in that environment with Journey Out dealing with who is a trafficking survivor. We don't have to be detectives in our clinic. We don't have to ask them a lot of probing questions. We just assume they've been through major trauma, and we just start from there. And like I said, if they want to share, great. If they don't, great. Sometimes they just want to be a person and ask about their sore shoulder or something like that. But our partners are essential. And our advocate, as I said, wears both hats. So it's really been a great bridge.
Thank you so much.
Mm-hmm.
Yeah, that's great. Yeah, I was going to say, I was feeling very jealous about the 1.5 hour appointments as an emergency physician. I was like, man, that's amazing. Makes me wish I worked in that environment. And that's part of why our model is a consultation model, because we just recognize very early on, it's hard to do this on the front line and do it well. Even if somebody really connects with you and they're willing to talk to you, all the stuff that comes after that to meet that person's needs, it just doesn't fit in the framework of the way we staff emergency departments or even busy inpatient units. So I love that you asked about partnerships, because when people come to me and they're like, okay, we think we want to do this in our system, what do we need to do before we launch? And I'm like, well, before you start educating and recognizing, think about what your service model is going to be able to do. And that's going to largely come from your community partners. So Safe House Project is one of our big partners, because they work with men, women, children, whole families, and they've helped us find places of healing all across the country. We do sometimes admit children. So if we have kids that really have no place to go, we will admit. And unfortunately, probably best case scenario, it takes about 30 days to navigate the North Carolina system. By the time you get all their paperwork, you get a clinical case assessment, you identify good places that might work for them, have them interview, negotiate a single payer contract from the LME, and then arrange transportation and all the things. It's a very complex, sadly, a very complex process. So hopefully something that other partners that we've talked to are working on for us at the state level. But then we also have a youth case management agency and a case management agency that works mostly with adults. We have a couple of therapists that we can refer to. And then obviously we work closely with our task force. And then we have a legal team in town that's amazing. So Moore Van Allen has a pro bono project, and they'll do everything from immigration to family rights to credit repair to expungement of other crimes. And they'll stage it in whatever order makes sense for the victim. So they'll even follow along with another partner case management agency, so you can get them involved early, but they'll step in when the time makes sense to help the client. And so that's been huge, because that's what's really the game changer for what you're able to do for the people that are willing to talk to you and tell you their story.
Absolutely. Thank you.
Yeah, and kind of just to reiterate what the other ladies were saying, you cannot do this work alone. You will get burnout in 5 seconds, because if you don't have your resources and those partners readily available during some of these, moments, sometimes they're emergent, sometimes they're not, it's just impossible. So it really takes a village. I remember when we first started our kind of CSEC advisory board, just pulling the community together, where people thought it was going to be, social services and law enforcement and, maybe one or two other, shelter type things. We literally had like 40 different organizations involved for all of the different needs, and we've even brought more on, like we work with our medical school, and I absolutely love the students, because they're so energized and they really want to understand how to interact with this population or anyone with trauma. So we've kind of added them into the mix because they're going to be in our emergency departments, screening some of these kids and interacting with them first, and knowing before they get to their, physician status that, what to look for has been amazing. So we do a lot of work with our medical school. And then we also have a legal team, pro bono legal team also, that helps, again, like Dr. Reynolds said, with some of the immigration or custody things, or, any sort of a lot of expungement stuff also for some of our survivors that have been with us for a long time. So there are so many different pieces to this, and not to be overwhelming with that, but just to realize it's a community-wide effort. We also obviously work with national organizations and called on Safe House many, many times to help with housing, which is just a small piece of this huge big picture of what needs to be all of the partners engaged in. So it can be it can be a lot, but can also be very energizing when people want to be on board and want to understand kind of what their place is and what their role is in this big picture of this, again, long-term survivor care. I mean, somebody asked I saw it come through the chat, what's your oldest survivor? And like I said before, we had somebody that I initially met when she was 15 and is still working with all of our, community partners and specifically with me. And she just turned 26 last month. So again, that continuity of care is so important. And yes, people are going to come and go in those roles, but keeping up that training with your community providers, getting those champions of people who want to be involved and want to be on that list of, the call list when, some of these needs pop up. So absolutely, community partners, invested community partners are just essential for this movement and for survivor care and for long-term things, education, long-term housing, employment. There's just so many. It really reaches so far and wide into the community, which is why we need all the help we can get to kind of have people on board for that support.
Absolutely. Our COO put together this eradication framework that is all about collective impact. And I think as healthcare is included in that, but I think when we often build our systems outside of thinking about who needs to be at the table, we leave healthcare off. Not we as in Safe House Project, but we as in like the collective we, because those are such private moments that we don't think about bringing them into this collaborative environment like task forces and coalitions. And it's so important when we're addressing the whole person and giving people the best chance at a new kind of life or a different kind of life. We've talked a lot about the things that you have built and how you've done that. Let's shift to some of the bumps in the road. What barriers did you encounter when you were trying to create or implement these solutions, and how have you navigated them?
Well, I guess I can always start again. Of course, money is an issue. I work for a wonderful not-for-profit organization, Common Spirit, but our director, Jennifer Cox, had to get funding, grant funding. We had to work with our local hospital foundation. And the interesting part of that is I live, our residency is in a suburban part of northern Los Angeles. And he said to me, "There's no trafficking here." And that was part of the barrier, as people said, "This doesn't exist in our community." And we found there was a ring at the local university that had just happened, So there's a lot of people who we needed to get support from that didn't understand the need. They were kind of horrified. I always said, they didn't really want me to go speak to all the older donors from the hospital because it was too, just too much for them to hear about. So you have to really tone it down. So those were tough barriers. I mean, we have money, we have funding. We do the same thing. Our advocate provides Uber rides for our folks. We meet them at the front door. Sometimes they show up with their trafficker, and we've had to deal with that sometimes. So that was an interesting time once we had to have a whole escape plan. And of course, our survivor chose to go back with her trafficker, unfortunately, that time. But we always say there's next time. And she knew we were there for her, and she knew that we had everything, and we could have gotten her out if she had wanted to that day. But we try to keep the traffickers out of our lobby. That's one thing. So we've asked that people that come with them wait in the car, not to be mean, and not to keep them in the California sun, but mostly because they often are their traffickers and they're trying to keep a short leash on them. So those have been some of the challenges that we've faced.
Yeah, absolutely. I heard from, I think, Gigi about a situation that had happened in Sacramento at the clinic in Sacramento where with an active trafficker. So that is, I mean, that is part of the practice, right, of serving people that are still actively experiencing
We've
it.
definitely had it a couple times, with us as well.
Yeah.
Yeah, and so I mean, we hit all sorts of bumps, but I mean, funding's definitely a huge one. That's a great call out. And then the other thing we learned quickly is we thought a lot of this would look like a sane response or like a forensic response. But what's different about trafficking is, if somebody's been sexually assaulted, they enter your ED for a sexual assault, they enter as a victim of crime, expecting to receive services as a victim of crime. And so if you go in and you talk to them in a trauma-informed way about their experience, they may not be willing to tell you all the details, or they may not be at a place where they can tell you the details in a linear way, but it's not unexpected that you're going to have that conversation. Trafficking patients, in our experience, really do not self-disclose. And so you're in the ED because you sprained your ankle, you hit rock bottom because of recent violence that you experienced, you're having a mental health crisis, or you got in a bar fight with a girl that's got nothing to do with your current perpetrator, but you're there as an assault that's completely unrelated to the true degree of violence that you're experiencing. And now we have to talk nurses and doctors into shifting that conversation and talking to that person about like their general safety and trying to get a sense of what's going on. And so many people, I think, are afraid to have those conversations, even though the literature bears out really well that patients are open to that. In fact, they'd much rather hear from their physicians and nurses and the frontline people that they're connecting with in the department than to have that relegated to a social worker or a separate person. So the other thing we realized too is when we wrote our first grant, we went to the Project No Rest team that was based out of Charlotte, and we said, how many cases have you seen in Mecklenburg County in the last year? They were like 44. So we're like, oh, okay, great, $100,000. We'll have a great social worker, and Em and I will be volunteers on the team. We'll have plenty of resources. We'll do mostly education. Well, we had 204 consults in the first year, and we got crushed. So I think really what you learn there is that when you're consulting, it's going to be people's understanding of trafficking or people's understanding of indicators, not necessarily law enforcement documented victims who are in active investigations. And so your numbers are going to be much higher. And if you're doing it well, not every one of the cases you get asked to consult on is going to be a trafficking case. So you've got to expect to see more cases than what your community is seeing and have a tolerance for that and have the resources in place to be able to handle that.
Absolutely.
So I think those are kind of our big ones.
Yeah, those are great. And I think the other piece, like something we've learned is as you do things well, people start referring to you, right? If you start doing things well, you get a lot more people that are willing to come and trust you with their time than you did previously.
Yeah. Yeah. We have a lot of people that think we have a human trafficking unit. And we're like, well, not exactly, but we'll help anybody who needs us.
Yeah, and I think we had very similar barriers. I mean, when we first started directly, having a program just for trafficking, survivors, adult and children, when we engaged with our community first and kind of opened up the podium for people to talk about what they were seeing, we had our local law enforcement stand up and say, and of course this is over a decade ago, was that, well, we don't have that here. We don't have trafficking here, but yes, we do sometimes arrest minors for prostitution. So there was kind of like silence in the room. We're kind of like, okay. So, I mean, that's basically where we started, from the very, very beginning of, kind of changing the mindset of what this really was going to look like. I think people had different ideas, especially in the hospital setting of what they were going to see as a trafficked person coming in through their doors, right? And so we really wanted to break down some of those barriers in doing things that were just kind of, I don't know, I guess for lack of a better way to say, just to kind of lower the threshold for all this fancy speak and posters and screening tools and all of that kind of stuff. And really just like when a child presents to the emergency department without a guardian who is, testing positive for, multiple substances, maybe pregnant, maybe, has multiple STIs, like we don't really need a screening tool at that moment. Like we have all those things, like something's going on here. So kind of just removing those barriers of like what people think it's supposed to look like. And maybe this child hasn't exchanged, sex for something of value at this point, but we have identified a very at-risk human being that needs a lot of support at this moment. So again, just kind of breaking things down and simplifying a little bit to make sure that people weren't over analyzing things and reassuring the community like, hey, we have all the things we need. We have the professionals we need. We just need to tweak a few things to make sure that, we're doing this in a trauma informed way. I think also as things have changed over the years with COVID and significant, uptick in children having access to devices, just shifting the way we do things, and people don't necessarily like change. And so, it's something when we go and teach, we always talk about that, like something something new comes up every couple months. Like you are constantly changing your perspective, your clientele that's coming in, how things work out there, what children are doing, what websites they're on, what they have access to. So it's an ever moving process. And I think that can be a barrier because that especially some of the old school people that have been doing this for 100 years, they like things to be consistent and look the same. And that's not the way, this works. That's not the way crime works anyways. But definitely having some of those barriers, having a large turnover of social work and, law enforcement that is not, that are there for a couple of years and then move on to something else, like having to retrain and get people back on board, that can be exhausting, and really making sure that you have the right people at the table and creating sustainable systems, which we spend a lot of time doing in our hospital to make sure that this isn't, something that has to be just one certain person can work in this group. Like we really spent a lot of time, we had one case where we had a child that needed to be medically detoxed from the substances that were, potentially fatal. And we had never done a pediatric, substance abuse detox in our hospital. And there was multiple in the middle of the night conversations like, well, this is our job. We have to do this. We have to have the right people to consult with. And, our hospital, was terrified. Understandably, the liability of this was just astronomical. We'd never done it, but really like, this is what this is one of our needs. We got to figure out how to do this. And it was kind of in real time that we did. And, this was just this child was, 3 weeks in the ICU. And I mean, it was all big guns were out to try and, to help this child recover. So really just not being overwhelmed with some of the big things that may surface, and really just kind of working through with your team kind of step by step. And there really isn't a blueprint because every community is so different, right? So when we do a lot of teaching in different communities saying like, you need to gather your partners, see what your resources are, what your community is able to handle, and what your professionals are able to handle, and kind of fill in some of those gaps, but also know when you have to maybe reach out to another jurisdiction for this type of care or this type of, resource or services. Really very community specific, I think is one of the things that is very important for people trying to create these programs, to make sure that your systems aren't too overwhelmed, because that's not going to be a positive experience for, the survivor or, the treating physician or service provider if everybody is overwhelmed. So really taking a good look at what resources are and making sure that your teams are built adequately to support the population of your community.
Yeah, absolutely. And as much as you guys are identifying barriers, I'm also hearing a lot of overcoming those barriers, which we would qualify as great success, right? Obviously, finding a solution for that minor who is experiencing that is an incredible success. Daisy, like the other success I'm thinking is, having someone who's continually coming and receiving care from you and staying in relationship for 10 years. As you said, it just turned 25, 26 is an incredible success, right? What other signs of success have you seen from the initiatives that you all have created, whether through outcomes or survivor feedback or staff response or systems changes?
Again, I can start. I think it's on two levels. One, of course, we've seen results with our patients. Our number one patient, our first patient we saw in our medical safe haven, just graduated from junior college, just got a job. Her two children, adult, not adult teens, our patients, and they're struggling, but we're helping them through that. Watching her go from that to getting this job. I mean, her graduation was such a big deal in our clinic. We celebrated, and we've had other folks who have gone on to out of safe houses, onto college. Obviously, not everybody, a lot of people, but those are the successes we try to remember and really support. We have had people who've been trafficked in the past come in with lingering depression, mental health issues, helping them get the mental health needs they needed because they never dealt with it before. That's a huge success. And that is something that we can really do well. So those are great, successes. On the other front, I like to bring up, because I am a physician, and so a lot talk about burnout in physicians. I'm at the end of my career, but this was life-changing for me working in this program. There is no burnout. I come home, I, just feel alive. I'm exhausted, but that time that you get to invest with these folks and get to know them and see the world from their view. And it's painful, it is. We do a lot of debriefing in our clinic with our young doctors. If there's a particularly tough session, we debrief right away. Not, we wait till the end of the session. But they all say they really get a lot out of the trauma-informed care and approach, and they comply it to other patients. I know that's not the focus of your group, but there's a lot of patients in our world that have been through domestic violence, other kinds of trauma, and these same techniques work for them. And they really, it opens the world to the way that they can be healers, which is what most physicians want to do. They want to be healers.
Yeah.
Yeah, I love what you said. I think that that's very, very true how you described it. What I'm going to talk about, it's going to sort of sound like a barrier, but I promise there's a silver lining on the other side of it. So in North Carolina, DSS was sort of handed the responsibility that trafficking cases would be reported to them. But unlike sexual assault or other forms of child abuse, there's no requirement for a temporary safety plan. There's no dedicated money set aside for that. There's really no specific protocol for like what needs to be provided to children who may be victims. And so this is the one and only crime, terrible crime that I see perpetrated against children where, DSS will do their best to be a partner, but they don't guarantee placement or helping to find resources for children. So in the beginning, we thought we would just identify and call the cavalry, and the cavalry would be DSS and law enforcement. And then we figured out pretty quickly, like, we got to build our own cavalry because that one's doing their best, but they're not going to really be able to help in this area. And so in the beginning, we had a lot of kids that we started labeling them excluded from treatment. I refused to call them kids who went home because we knew home wasn't working for them the day we met them. But we exhausted all these options and then wound up setting them home sort of in defeat to try to work with outpatient options. Most of them ran again and did not get the services that they needed. We have watched that change over the last 5-6 years so that, I mean, it's maybe now like one a year that actually get excluded from treatment. And I'm not saying that the first option always works or that kids don't rebound or relapse or that there aren't setbacks, but I don't see nearly as many, the number of kids where we had nothing to offer, we're in a totally different place from where we started. And I feel like that's a huge victory.
It is, absolutely. Yeah.
Yeah, I definitely can concur with that. 10, 15 years ago where we started out and now where we are now, it's something that we talk about all the time in our debriefing and case reviews also, is to kind of just take a look back at how far we've come when we feel like we've been frustrated. But that has been amazing to watch the progress of our community. We still have a long way to go, but really seeing how many people now are so engaged and, want to support all the different agencies that provide the direct service. I probably have a million, and I'm very intentional about making sure that I have these success stories because people want to hear that. And I also need to remind myself, because again, this is a marathon, not a sprint, right? When you interact and provide services, but really creating a place within our hospital system where these kids feel safe is one of our biggest successes. It's one of the things that we say if they're going to leave, or not, against medical advice, or that, they're not in a situation where they can stay, or there's just a lot of things going on, knowing that they can always come back no matter what. And we had a very difficult case once where we had actually an emancipated minor. So she was 16 years old, but she was emancipated. So she had the rights of, an adult. And it was very difficult for our physicians to interact with that in terms of just the feelings of, we can't let her leave, she has to stay. There was some significant health issues going on and she wanted to leave. And so we really had to have those difficult conversations. Like, we don't want to put her on a hold. That's not appropriate in this. We had mental health come in there and screen for that. That was not an appropriate way to keep her there just for another 24 hours. And having those conversations, and everybody just left, like, just had this horrible feeling that night, like, we have to let her go. But, we hope that we've created an environment for her to feel safe coming back, because we knew her trafficker was literally outside the door. There just was not a lot that we could do at that point. And, we let her know, at any point in time, this is a safe place for you to go. We didn't force her to stay there. And that was, a huge for her to not be forced into something, knowing that she, needed to be, have the rights of an adult. And literally the very next day, she came back in and said, that meant so much to me. I could feel like I can trust you all now because you didn't, try and put this emergency hold on me, which again, we would have had to manipulate the system to be able to do that. But, those are our successes where, she was treated well, her rights were protected, as a minor and as an adult. And, we provided the best care for her in that moment. And she had to leave and figure out how to do things on her own, and then was able to return to that safe place. So I think that's definitely one of our biggest successes, that happens quite a bit. Even again with adults who have turned 18, like, well, this is a children's hospital, I can't come back. We're like, you can always come back. And I'll have sometimes, the person in the lobby calling me and they're like, is there somebody named Daisy? Because this, 19-year-old is here swearing that you were told, you told her that if she ever needed help, she could come back. And, so those are just life-changing moments for me, to, again, that, getting that energy back from kids who, are listening, maybe going in one ear out the other, but at some point, something that we're saying is sticking. And we like to say every interaction is an intervention. So really making sure that, even that 5 minutes, if it's the 5 minutes or it's the hour and a half you spend with somebody, that the things that you say and what you do and how you are treating this person, this human being, is, going to shape what they do next, right? And it may be 5 years before they come back, it may be the very next day, but kind of just keeping that, in your head. So those successes are very important. They're very important to talk about. They're very important to encourage our community. And also, like you both were saying too, it's important to get yourself energized that way, so there is not burnout, and you really, your cup is filled, with this population. I can't imagine doing anything else. I've been in this for 20 years. And the amount I get back, I feel like sometimes is, people don't get to see that part because a lot of this is confidential, and especially with minors. But that is a
Yeah.
huge reason why I'm still in this, because these kids, these young adults are just absolutely amazing. And I love, interacting with them.
Yeah. And somebody's asking, I believe you said every interaction is an intervention, right? So yeah. We're at 9:56. I want to ask one more question, and this question is from our Q&A, and I'm excited to hear what you all say to this, because obviously not every medical system, not every survivor who needs medical care has the opportunity to find intervention in a system like what you all have created. So do you have any advice on how to advocate for a survivor who is in a medical setting if they don't have access to great services like this?
Well, we try to teach our patients how to advocate for themselves when they go to see a specialist, when they go to the radiology department, when they go anywhere. In the beginning, if we have a really troubled person, we'll send our advocate with them. But that's part of what we do in the medical safe haven, is teach them that we're not always going to be the one seeing you, and that they're going to have to learn to advocate for themselves. Tell them all of the rules about a doctor has to ask permission to touch you. And they're like, really? Some people say, I thought a doctor could do anything they want. Oh, no. And so we teach them, no, this is how you should be treated. Always stand up for yourself. So we do try to do that. Obviously, we have a long way to go. There's a lot of people that need this education.
Absolutely.
Well, I was going to say, you can change your own practice well before you change the system. So just learning more about your community resources and what's out there to refer to patients. I mean, if you're working in a busy setting, you might not be able to do a full scale response, but there's models out there for meaningful things you can do just by providing education and saying, here's partners in town that you can go to, when you decide you're ready, and you can come back to us as well. So I think, and also just learning more about it and understanding the problem, being a more informed consumer, a more informed juror, a more informed advocate at your PTO meetings for this issue, I think are all valuable ways to jump in.
Yeah.
Yeah, definitely agree with both of them on that. We do a lot of education also, and empowering and teaching kids and teenagers how to advocate for themselves, and that is something that goes a very long way and kind of extends into other areas of their life. So it is so important to learn how to advocate for yourself in the medical setting and really understand your rights. And a lot of times when we teach, we reminding physicians, like, a 16-year-old has rights, about her reproductive health, and making sure that from on that end that is respected, that those rights are being explained to them as well. And then on, the side of the minor, of really letting them, be able to ask those questions, to feel, trusting their instincts and advocating for themselves in that setting, teaching them how to do that, because that's not something that kids are taught. Really, you go to a medical professional with your parent until you're a certain age, and then you kind of do it on your own. But I don't even think we teach kids, college age kids that are leaving their parents and going to their own appointments. There's all these jokes all over TikTok about not knowing how to fill out your forms at the doctor's office, and having questions asked and answered. So I think that's good for everyone to understand, but that piece of advocating for themselves, again, carries so far out into the rest of their lives and gives them that confidence to do it.
Absolutely. Well, thank you all so much. I appreciate you coming and sharing your expertise and giving us a glimpse into these models and the way that things can be done differently than what has been the status quo. And I hope that we'll be able to stay in touch and use your systems more and more. Next month, we are going to be talking about leadership in the anti-trafficking space, and I hope to see you. Thank you again.